there are a lot of specifics that nurses need to keep in mind as they are administering this herpes simplex modified virus to patients, because accidental exposure is of concern both to the patient, to their family members, as well as to healthcare workers. I always recommend nurses wear personal protective equipment, such as a gown, safety glasses, gloves, and or a face shield.
You're listening to the ONS Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello and welcome to the ONS Podcast. I'm your host, Jamie Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Heidi Finnis, Director of Ambulatory Pharmacy Clinical Practice at Mayo Clinic and Assistant Professor of Pharmacy at Mayo Clinic Alex School of Medicine in Rochester, Minnesota, about oncolytic viral therapy. This episode is part of a series about anti-cancer drug classes, which we'll include a link to in the episode notes. As a reminder, this episode provides free NCPD contact hours. To receive credit, please review the episode notes for any guest disclosures before listening. Following the episode, complete the evaluation linked in the notes. Welcome. Thanks so much for joining us today, Heidi.
Thank you for having me, Jamie.
So to start things off, could you give us a brief overview of the history of oncolytic viral therapy in the field of oncology?
Viruses have actually been investigated as potential cancer treatments for more than 100 years. Anecdotally, patients with cancer had regression of tumors after natural viral infections. But unfortunately, because viruses are cleared so rapidly, those remissions were usually quite short-lived. There have been formal efforts to use viruses therapeutically beginning in the 1950s, where patients received wild-type viral isolates in small cohorts of cancer malignancies. This approach was limited because of the lack of that virus's tumor specificity, its unpredictable toxicity, and there was an inconsistency really in the efficacy of those viruses. Where I think interest has really been revived was in the late 1990s and early 2000s, where there's been an emergence of recombinant DNA technology and genetic engineering, which allowed for viruses to be modified or enhanced, if you will, so that they're more tumor selective, more potent, and safer to the patient. This shift really in focus from finding viruses through intrinsic or innate pathways to designing viruses that have selective replication within cancer cells led to the FDA approval in 2015 of an oncolytic virus called telimagene laherpapirepvec. It's a second generation oncolytic virus that's targeted, or that's from the herpes simplex type 1 virus that has been approved in unresectable or recurrent melanoma after initial surgery. It was approved really based on the Optum trial that demonstrated a durable response rate of 16.3% versus sargramostim or GM-CSF control arm, which had a 2.1% durable response rate. And so it caused regression in both injected and distant non-injected tumor lesions in patients with melanoma. This really suggested that systemic anti-tumor immunity occurred by targeting cancer cells specifically.
Wonderful. Thank you for giving us that history. It truly is a sort of a fascinating approach to how we are finding more effective ways to treat certain cancers. So I'm excited to talk a little bit more detail about that. Let's go a little deeper into the actual mechanism of action. How do these oncolytic viral therapies actually work?
Oncolytic viruses exert their kind of anti-cancer mechanism, if you will, in two ways, is really the way I think about it. They can have direct lysis, if you will, to the tumor cells themselves, or they can cause what's called activation of the immune system or immunogenic activation. And basically what they do there is they release what are called tumor-associated antigens and then pro-inflammatory signals. So think of like T cells, natural killer cells, those sorts of things. that can convert what are called immunologically cold tumors. Those are tumors that are basically immune silent into hot tumors, which are now immune activated. And so by doing that, they recruit those T cells and other cells to the area to attack both the primary tumors, but that's also thought to be how they work on distant or non injected sites as well. So, this immunomodulatory capacity has led to the reclassification of oncolytic viruses as really a form of cancer immunotherapy. So, think of it kind of similarly to how we think of immune checkpoint inhibitors in recruiting immune cells and leaving our immune system in the on position. This is also kind of a form of immunotherapy.
And we know certain therapies require sort of biomarker testing or qualifying eligibility type conditions that a person would need to be eligible for this type of therapy. So are there any of those type of biomarker tests or other sort of clinical indicators that would let a nurse be able to anticipate if someone would be prescribed an oncolytic viral therapy?
Can I say not yet? There's really no specific kind of the biomarker companion tests that we think of, like with BRAF inhibitors or EGFR inhibitors that are required right now with oncolytic viral therapies. But I know that there are lots of things that are under investigation that may correlate more with vaccine susceptibility, such as Nectin-1. Sometimes we look at baseline CD8 T cells. We might look at herpes simplex virus serostatus in people receiving the virus so that they don't develop a herpes infection. But to my knowledge, right now, for the nurse or the pharmacist that is administering or preparing this medication, there's nothing that the patient has to test positive for these oncolytic viral therapies.
Now, I know you mentioned one agent specifically, but are there any other subclasses or are there any other ways that we sort of categorize oncolytic viral therapy? And are there any other examples that you'd want to highlight in more depth?
So I think of these as generally two kind of classes of oncolytic viral therapies: the genetically modified viruses like telemagene. There was also another genetically modified virus that was the next generation of telemagene recently in clinical trials called busilimagene. However, that medication on April 10th of this year was not approved by the FDA in its second attempt at approval. The other type of oncolytic viruses are those naturally attenuated viruses that directly cause lysis to that cancer cell, whereas the genetically modified viruses tend to recruit different immune cells to that area. The naturally attenuated viruses cause death immediately to that cancer cell.
And so, what are some of the common toxicities or adverse events that we typically associate with oncolytic viral therapy?
Oncolytic viruses are generally fairly well tolerated. The most common side effects I think of in two categories: really flu-like symptoms, which can be headache, fatigue, maybe a little bit of fever, perhaps some nausea. And then the second group of side effects is really injection site reactions. So patients may have itching at the site or a little bit of pain. As we look at more broadly, as more oncolytic viruses become available in the future, the adverse event profile is really going to differ, probably based on the virus type. So telemagene that I've mentioned is a herpes simplex virus type 1, how those viruses are delivered and whether the agent is used by itself or whether it's used in combination with other immunotherapy or chemotherapy. One of the toxicities I know that is of significant concern to patients, to family members, as well as healthcare workers is the incidence of herpes infection. Systemic herpetic infections are extremely rare and usually more common in patients who are perhaps immunocompromised. In patients who also have other immune-related diseases such as vitiligo, vasculitis, pneumonitis, sometimes worsening psoriasis, because you're mounting an immune response with these types of things, sometimes you can see a worsening of those types of immune symptoms. But for the most part, these types of side effects are really very well tolerated in most patients, and they don't have a lot of complaints on subsequent administration of oncolytic viruses.
For the toxicities that you've mentioned, are there pharmacology related strategies that can be used to help either prevent or maybe manage the toxicities that could develop?
For the flu-like or constitutional symptoms that I mentioned, like fatigue, fever, chills, these types of side effects can be commonly managed with supportive care, like over-the-counter acetaminophen, some ibuprofen if patients have adequate kidney function, ensuring patients are adequately hydrated, and if needed, antiemetics like ondansetron or prochlorperazine or any type of prescription antiemetic could be prescribed should patients need that. I do want to mention that sometimes symptoms can occur early, but for the most part, symptoms tend to diminish with subsequent cycles. And usually a maximum of 3 days or 72 hours is the timeline for these symptoms to occur. I think the important thing to remember with treating patients who have injection site complications, we want to rotate the injection sites of these patients. And so, again, in any necrosed or ulcerated types of tumors, we don't want to give an injection into those sites. Sometimes, very rarely, cellulitis or bacterial infections have been reported. And so, ensuring proper care, potentially antibiotics, ensuring that patients are healing from prior injections is going to be very important, as well as not having radiation to any of those injection sites. I think will be important to ensuring that patients heal well as they receive these injections.
As you mentioned, this is administered directly into lesions or known tumor sites. And so, can you talk a little bit more about the unique administration considerations that nurses should keep in mind for this type of oncolytic viral therapy?
One of the things that I think is most important for nurses and pharmacists to advocate for within their institutions is a guideline for how these types of medications will be administered. As you mentioned, there are a lot of specifics that nurses need to keep in mind as they are administering this herpes simplex modified virus to patients, because accidental exposure is of concern both to the patient, to their family members, as well as to healthcare workers. I always recommend nurses wear personal protective equipment, such as a gown, safety glasses, gloves, and or a face shield if that makes them to feel more comfortable when they prepare or draw up the oncolytic virus, and particularly when they're administering as well. Should the healthcare worker have any exposed wounds, they need to be sure those are covered before they prepare or administer the oncolytic virus as well. As they're administering, generally I recommend that you swab the injection site and the surrounding area with alcohol and then wipe once you administer the agent and cover it with an occlusive dressing. You wipe the exterior of that dressing with alcohol as well. Generally, patients should wear dressings, particularly as prescribed with Clemagene, 7 days or longer, particularly if that site is oozing or weeping. All hazardous materials or all dressings, anything that you use as you're administering the product should be disposed of as a biohazard waste. Other things that I want nurses to know in particular is do not prepare or administer oncolytic viruses if you're pregnant or immunocompromised, say you're undergoing cancer treatment or treatment for an autoimmune disease. Another important thing for nurses and pharmacists to check in patients before they dispense the medication is patients should not be taking acyclovir, famciclovir, or valacyclovir, or prednisone, because the acyclovir, famciclovir, or valciclovir can inactivate that herpes virus because the virus is very responsive to those medications. So we don't want our patients on prophylactic, or if they have cold sores and are actively being treated with those medications, to receive Clemagene or other oncolytic viruses at the same time. The same with corticosteroids. We don't want anything that's going to suppress the immune system such that that would make the oncolytic virus not work very well. With regards to creating an institutional guideline, I know as nurses and pharmacists, particularly as soon as these medications come out, We get a lot of excitement at our institutions and our sites about administering these. But I think having an institutional guideline is really a step that protects all of our healthcare workers as well as our patients. And in that institutional guideline, I think we need to include things that highlight material safety data sheets. So all of these viruses are going to have a lot of data behind them that will include how one needs to prepare and administer, as well as the biodistribution and the shedding of these types of viruses. I think we need to have in that institutional guideline also how to mitigate exposure. So, how is that virus going to be transmitted? So, telemagene is only transmitted generally via bodily fluids or touch. It's not airborne. So, herpes simplex virus isn't an airborne type of virus. Other things to consider is where are you going to inject this? Are you going to do this in your infusion therapy unit? Are you going to do it in a dedicated room? Who's going to escort the patient to the room? How is the virus going to arrive at the room? How will you clean the room and all of the laboratory equipment or any of the exam tables that may be in there? Having all of that kind of discussed and assigned mitigates the consternation sometimes that can occur, the fear that occurs with administering a virus that is thought to be fairly communicable, although I would argue it's very easily inactivated. In addition, I think communication, again, understanding who's responsible for what part of the workflow, and education. How do you ensure all staff members are appropriately educated as to the risks associated with administering oncolytic viruses, to what they need to do to protect themselves and to protect the patients that they're serving, and then how to proceed in case of exposure. Ensuring everyone knows kind of those steps, I think, will help to ensure oncolytic viruses are considered as appropriate treatments for patients, but I think also make everyone feel safer and more secure as they're administering these as treatments for cancer patients.
I really appreciate you calling out a lot of the logistical pieces that really need that thoughtful consideration before starting this therapy and at a site of practice. And I recall in a former role of mine when this drug first came out, those were the meetings that we had to have because, there's just so many unique aspects to this type of drug, as you mentioned, like not only, I think the clinical competency and making sure that the clinicians who have the right appropriate privileges or how the policy outlines at that institution who can give this type of injection because it is sort of a procedural type of administration versus just a basic sub-Q injection. This is something different than that. And so not only assigning clinically who is the appropriate person to give this and do they have the training and the competency, whether, as you mentioned, like the whole logistical piece of where it's going to be done. Do you have all the equipment that you need? Explaining the difference. This is not chemotherapy. It is immunotherapy, but also a very unique type of immunotherapy. And so I think you did a great job of just highlighting how complex this drug is in the upfront sort of initiation phase of getting all of those sort of pieces and parts connected and just how sort of cross-functional and interdisciplinary those initial conversations need to be.
I think all of those people definitely need to be at the table, and consideration needs to be given to obtaining all of the information and ensuring folks are comfortable as you move forward with this product. But I think that's often the hardest part is the operationalization of an oncolytic virus.
And also then how often will it be given? You may have one patient who is eligible and ready for this therapy, but if it's not something you're going to see often and repeatedly, then it has become that concern of like, how do we make sure everybody stays ready and kind of up to date on how this procedure takes place? And so that can also be a complicating component if it is not something that, if you don't have enough patients getting it regularly, of how do you keep everybody sort of fresh and ready for the next patient?
You bring up a really good point, Jamie. I think as an institution, you have to decide, are you going to take on, or are you willing as an institution or a healthcare site or a clinic to do this? Or are you going to refer patients perhaps to another site within your health system? And that's going to be the site, because the competency is such an important thing to keep patients safe, to keep health workers safe, to have medication on site. There are a lot of different storage requirements. This has to be stored in a minus 80-degree freezer. You have to have the different doses on site as well to start versus more of the subsequent cycles that you're going to receive. And so all of those types of things are going to be important to consider as well.
And we see similar circumstances in other unique administration routes when we think of like intraperitoneal, intravesical. If it's a kind of a volume question of like, if where you work, if you are going to be doing it frequent enough that it justifies some of that startup planning and all of that, then it might make sense to train your staff to be able to give these types of administrations. But if not, then maybe that is, like you said, the appropriate plan is initially to have a centralized place or a place where you'll refer patients for this at sites that have maybe a higher volume, a more regular volume of these patients who are receiving therapy. So just a unique consideration when thinking about this drug, for sure. So what are some of the primary patient education points that we should be communicating to our patients and their caregivers when they're receiving oncolytic viral therapy?
Just helping patients to understand really how this works. Because I think maybe hearing that you're receiving a virus, particularly a herpes simplex virus, can be scary to a patient. So I think understanding that it's modified, or essentially we're taking out the parts of it so that we can directly inject a portion that recruits immune cells to that area, because the goal is, again, to inject into the tumor for the oncolytic virus to attack cancer cells and then destroy them by triggering kind of an immune response in the body. I think the other thing that's important is that side effects generally will occur early. Patients can become a little bit more tolerant to them as they receive subsequent cycles, especially in early cycles. Most of those flu-like symptoms, tiredness, chill, pain at the injection site go away usually within the first 72 hours.
How do you see pharmacists and oncology nurses collaborating to manage the adverse events, the toxicities, provide that patient education you just described, and really just serve as a trusted collaborative source of information for our patients and their caregivers?
I think one of the things that nurses and pharmacists do well is in how they talk with patients. And I think being honest, really ensuring that the patient has a person that they can ask questions and kind of express maybe some of their fears. I think some of the things we do well too in collaboration is kind of reiterating some of the things that the patient can expect so they get a better picture of what is going to go on as I receive this oncolytic virus. I think as a nurse and a pharmacist, we also play a huge role in dispelling some of the myths that are associated with these oncolytic viruses. And one of the things that I hear commonly is that receiving this virus is going to cause me to have a herpes simplex virus type 1 infection, either in myself, my family members, or my loved ones are going to be put at risk, or the healthcare workers themselves can feel at risk with administering this type of a vaccine. And as I mentioned, Limagine specifically, I think, is really interesting in how it works because it deletes something called ICP 34.5, which promotes preferential killing of tumor cells. And then it has selective replication in tumor cells themselves. So it basically encodes, if you will, a genetic kind of cassette for sargramostim or GM-CSF that recruits those immune cells to that area to cause death to that cancer cell. But then because it replicates only in those cancer cells, it leaves healthy cells alone. Theoretically, it can treat only the cancer cells and should leave any of the other cells that wouldn't be infected, if you will, by this herpes simplex 1 vaccine carrying type agent in the body. Another myth that I hear commonly is that patients that receive these types of vaccines will shed the virus. And so I know sometimes patients are very concerned about urine in the toilet, bodily fluids, kissing loved ones, holding hands, hugging. Am I going to infect my loved one because I'm getting this type of an oncolytic virus therapy? I like to reassure patients that they can continue to hold hands and hug their loved ones as normal. Viral DNA is usually only present on the injection site. And as I mentioned previously, we want to cover with an occlusive dressing that injection site, at least with Limagine, for up to 7 days, and particularly if those injection sites are at all oozing or weeping. Active virus is usually only on that injection site itself. Many of the shedding kind of studies have shown that at 30 days after telemagene treatment, there's no DNA in the blood, there's no DNA in the urine, in the mouth, or in the genital area. Even at 60 days after treatment, there's no DNA at the injection site. The key takeaway is yes, it's a herpes virus, but there's not so much, I think, to really be worried about it as long as we use those proper kind of steps in how we administer and prepare things. We use occlusive dressings and the standard precautions. TVEC is the common name that we use for it in practice, especially in melanoma and skin cancer practice where I work. But it poses really very low risk to healthcare workers and to patients, family, and close contacts as they get home.
What do you think the future looks like for these types of oncolytic viral therapies and their continued role in the landscape of cancer care?
I think the short answer is oncolytic viruses are going to have a role in combination with other therapies. There have been several clinical trials specifically looking at oncolytic viruses in combination with immune checkpoint inhibitors. As I mentioned, I work in skin cancers and with melanoma patients particularly. There have been a couple of clinical trials looking at the use of telemagene in combination with pembrolizumab that have shown good overall response rates, but unfortunately didn't really hold up in looking at prolonged progression-free survival or overall survival. I think the question is, what is the virus really trying to do? I think we know that viruses like telemagene can convert immunologically cold tumors. So again, that means they're immunologically silent to hot tumors, meaning they are more immunologically active and they'll respond to those immune cells that are recruited to that area. I also think where oncolytic viruses will live is in how they're going to be used. I think one of the advantages that I haven't mentioned previously is oncolytic viruses, because you're directly injecting them into likely visible tumors, if we're doing that in our infusion centers or in our exam rooms in our clinic, subcutaneous or tumors that have metastasized, but we can still feel them and be able to inject them. These also have what is called an abscopal effect, meaning they don't just have activity because they're revving up the immune system on the tumors that we inject, but they also can have effect on tumors downstream from that. Because of that, there's lots of potential for oncolytic viruses to be combined with all sorts of different cancer treatments. I've been in practice now for 25 plus years in oncology, and I recall one of my attending providers years ago saying vaccines, viruses, immunotherapy, chemotherapy, targeted therapy, all of these things, there's going to be a combination. It's just figuring out when and where these types of treatments will need to be inserted for particular types of cancer and where they might be most beneficial. I think it still needs to be told in clinical trials to come.
Well, Heidi, thank you so much for joining us today on the podcast and talking about the oncolytic viral therapy. Is certainly a fascinating topic. And as you just described, I don't think we're done hearing about them yet. The more we learn about the immune system and find different and unique ways to harness it to help fight and be part of our other modalities of treatment for cancer, I think, as you said, we'll continue to see this show up in the landscape for many years to come. As we reach the end of our episode today, we'd like to always run through a series of quick questions just to help summarize some of the great points that we've discussed today. So to start that off, how do you believe healthcare professionals should evaluate their own hidden or implicit bias that they might carry about oncolytic viral therapy?
I think just by being open to information and curious to information as it comes out regarding these types of treatments, not letting the being concerned about herpes virus or other viruses that may be carriers for these types of treatments, continuing to learn more about it and how can we implement these safe opportunities for patients within our own institutions.
And what are some of the common misconceptions about oncolytic viral therapy?
I spoke really about the two most common ones that I think of, reiterating really that oncolytic viruses don't cause active viral infections, particularly in genetically modified viruses, which are many of the oncolytic viruses that we are encountering in today's treatment and in clinical trials, but also the FDA approved limagine product. That is a risk, but the risk is very minimal. There are very few patients that have disseminated herpes simplex infections. And as I mentioned, the shedding data I think is very encouraging to patients and to healthcare workers in simplifying, I think, some of what we do. Because these are viruses, oftentimes, at least in pharmacy, we create these procedures that are very cumbersome where we have to prepare these in a biosafety level hood too, when in actuality, really looking at the data associated with these, we could make them as long as we do adequate training and cleaning of our personnel who are putting together these either in the rooms that we're administering them ourselves or in biosafety level 1 hoods associated with that. It's again just ensuring everyone is educated and doing the proper safety mechanisms and cleaning hoods and cleaning surfaces because these viruses are very readily inactivated by antivirucidals agents as well as acyclovir.
Similarly, what's something about this topic that's not often discussed, but you wish people knew more about?
One of the things that I think people, especially in pharmacy, get excited about is because these agents have to be stored either in a minus 80-degree freezer, they say we can't do this because we don't have room or we don't have a dedicated freezer, particularly for the virus. One thing I do want to mention is a lot of the manufacturing companies have come up with ways, particularly shippers, if you will, that allow for storage of the vaccine for a certain amount of time. So, for example, telemagene comes in a shipper that you wouldn't have to open. You would just have to time kind of your order associated with that and then open the shipper within, I think it's 4 days that the shipper is good for. Space is always in such short supply, I think, in treatment areas, in different rooms and things like that, especially in the pharmacy. You wouldn't have to get a big 180-degree freezer, looking at ways in which can you just store the shipper, have that in time ordered for a patient based on when their treatment is. Getting that just in time shipment would mean you wouldn't have to have some of those special tactics and storage areas that may be of concern.
What additional training or education do you think oncology nurses need to stay current on this topic?
I think podcasts like this are really helpful, having forums in which they can ask questions, particularly of other nurses and APPs potentially who are administering these types of medications can help dispel some of the fear that may be associated with these medications, because I think that fear comes from not knowing. And so having resources available, there are several great review articles that are out there to really kind of quash some of the concerns that may be out there as to why we can't administer this to some of our patients at our sites because of the cumbersomeness of oncolytic virus.
And then are there any additional resources that you would recommend for patients or other healthcare professionals who would want to learn more?
The manufacturers themselves have very extensive resources associated to oncolytic viruses. And so I encourage you to check out the websites that those manufacturers have associated with their products. They have a lot of great patient information that can be given to the patient. ONS, HOPA, ACCC, and NCODA has a great resource in their nursing education or patient education sheets. Those are a great resource as well. Encourage you all to read more to become more comfortable on this topic.
Well, Heidi, thank you again for joining us today on the podcast. I really appreciate your time, and I've certainly learned a lot. Do you have any final comments to share with our listeners today?
I appreciate you having me here today. Thank you so much. I appreciate talking about this topic. I'm happy to be available to answer any questions should people need that. I think, again, continue to be curious. The way in which viruses maybe have been portrayed in the past is not the way these genetically modified viruses have come to life or will be in treatment in the future. And I think we continue to advance the science and how these work and how they will work in concert with other treatments.
Wonderful. Well, thank you again, Heidi.
Thank you.
Thank you for listening to the ONS Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.